This conference will now be recorded.
Okay, welcome people to the class. So today, the class is about the fetal monitoring in the labor because NICE guideline has been updated. So just about the update and also discussion how your answer will change. Okay, though it is not too much change, but yes, the change is there. So I'll try to cover the topic. Okay, so new guideline, what they want you to, they should be, supported decision making like what a fetal monitoring, what are the options are there that to be discussed with the woman in the antenatal period, and the discussion has to be documented. And it is not during the antenatal period but throughout the labor. We already know that the fetal monitoring keeps on going, and there would be the change according to the stage of labor and whatever. So like patient and their birthing companions or the family member, they should be explained everything about it. So this is supported decision making or shared decision making. Recently you might have heard, and I have taken class already for that, WHO labor care guide. Even these days the partogram, as you already know, has been changed over by WHO labor care guide. So in the WHO labor care guide, they have already put big column for the shared decision making. Okay, and this question was asked whether it will be in the exam also. Now, what are the general principles? It has to be monitored in the labor every hour. If you see the WHO labor care guide, they have got a column, and each column represents 1 hour. Okay, so what we have to measure: frequency, length, and frequency, length, and strength of contraction. Then if any risk factors are there, and current well-being of women and also the baby, and how the labor is progressing. Okay, birth companion is a or the patient already involved. Now this part, I put it here: strength of contraction. In NICE guideline, strength of contraction is there, but if you guys go through the WHO care labor guide, they have removed the strength of contraction, but I can't remove it from here because it is in NICE it is still there, strength of contraction. Though we can understand that gauging strength of contraction is very difficult. Now, fetal heart monitoring, like on the basis of fetal heart or CTG, we can't make any decision or choice. It is always, always a overall clinical picture, including antenatal risk factor, intrapartum risk factor, maternal risk factor, fetal risk factor, along with the CTG, okay, and the labor progress. Everything will come when we decide or take any, yeah, management for the patient. So it is shared disease. So it is, overall picture that would help. Okay, on not on the basis of CTG, you can decide upon anything. Now, fetal monitoring. So what are three methods? So we do have three methods: it's intermittent auscultation and CTG and telemetry. Everyone knows about it. Now, like there should be antenatal risk factor assessment. According to that, it will be decided that whether intermittent auscultation or whether CTG to be offered. But as the labor is a continuing process, so risk assessment is also continued. Maybe you, when the patient came and you started with intermittent auscultation, but if any new risk factor comes up, your mode of fetal monitoring will change. Okay, and like and there could be possibility that from the antenatal risk factor you tried doing CTG monitoring, but after 20 minutes, you find out that the patient is doing well, so you will switch over to intermittent auscultation. This question is asked in your exams also. Apart from this the third line is important to know: if there is no identify factors and you are doing CTG, then there would be increased interventions as compared to when it is done in the intermittent auscultation. So it is real important: if there is no risk factor, then CTG monitoring should not be done. Otherwise, there will be increased interventions. You guys have to remember this because it can come in any stem of your SPA, or role player can ask in the part 3 stations. Now, Okay, so just a small question. I put a question. So, what is the false about intermittent auscultation in first stage of labor? So, the patient is put on the intermittent auscultation. What do you think is the wrong from here? So, anyone can answer. Done by Pinard or Doppler ultrasound, and acceleration deceleration is recorded, palpated for 1 minute, repeated once every 5 minutes, and record as on a partogram or in the woman notes, or palpated contraction for 1 minute, repeated at least once every 15 minutes, and recorded as a single rate on the partogram in the woman's note. So, what is the wrong answer?
Ma'am, the third one, where the
Yes.
repeat is every 5 minutes.
Yes, because it is done every 15 minutes. So, this is the wrong answer. Now, this is the intermittent monitoring. This is the peanut stethoscope. Okay. So, this is used, and this is a Doppler. Okay. We, like Doppler, everyone knows we are using it regularly in our clinics and hospitals. This Doppler is very handy and easy. You know that. And we use this method. But guideline says this also. I have seen this and I have tried, but I was unable to hear anytime fetal heart. I don't know how they UK people hear from this peanut, but yeah, we are using this. So, but the guideline recommend these are the methods. Okay, so either peanut. So, when the intermittent auscultation to be started, when the woman is in established first stage of labor. Okay, and the guideline recommends either PNAD can be used, so this is PNAD, or either Doppler ultrasound can be used. These are the modes of intermittent auscultation. So, and it is calculated, this from this line question comes in your exam. It is palpated after a palpated contraction for at least after contraction, it is done for 1 minute time, and it is recorded as a single rate, and it done every 15 minutes, recorded as a single rate. What does it mean? Like many time, you will write, you will see people write any 150 to 140 to 150, so you are giving a range. So it is not a correct calculation. You have to say either it is 144 or 147 or 146. So this kind of single rate you have to do. And once the contraction is passed, complete 1 minute, you will after contraction gone, you will count it for complete 1 minute, and you will give it as a single rate. So, and it is palpated every 15 minutes time. Okay. Now, while auscultation, if any acceleration or any deceleration is there, it has to be recorded. Okay. And another issue that can happen, that whether you are it is very common, whether you are seeing maternal pulse or fetal pulse. So like you have to differentiate it. And like ma- uh, maternal pulse has to be checked every hourly. Now, there could be scenario when we try to do with the intermittent auscultation is though no fetal heart. What is the next step? Next step would be USG, real time USG. So you have to do the bedside scan, and you have to look for the fetal viability, because there could be many of the issues. Sometimes your instrument, sometimes your instrument is not working well, sometimes you are unable to hear, or sometimes the patient is obese or something polyhydramnios, and there could be possibility that you will not be able to listen from the PNOD or Doppler. In that situation, what if you are not getting, please do arrange bedside scan or urgent real time ultrasound assessment. Okay, this may come in your question. Now, income from second stage of labor. We already know this from the previous guideline also. Again, after contraction is passed, for 1 minute, fetal heart is recorded, but here will be every 5 minutes. So, first stage of labor, every 15 minutes we are looking at fetal heart, and at the second stage of labor, we are looking every 5 minutes. And like if the difference, ideally differentiation between fetal heart and maternal pulse to be there, and if there is any problem, not unable to differentiate between maternal or fetal, differentiate between maternal heart rate and the fetal heart rate, then either take help from the senior, or you do another method of monitoring. another method, change to any other method of the finding out the fetal heart. Now, what they say, if on the intermittent auscultation there is increase in fetal heart rate by 20 minutes and from the start of labor, or a deceleration is heard. So, what to be done in that scenario? This is new added in the guideline. In that condition, what they want you to do intermittent auscultation more frequently. That means after every 3 contraction, you will do fetal heart rate monitoring. Previously, what we read, that every 15 minutes we are doing fetal monitoring, but this is the scenario they have given. If you record increase in fetal heart more than 20, or you listen a deceleration, then please do intermittent auscultation more frequently, that every 3 contraction you have to auscultate. Okay, so this is a new change in the guideline. You should know because you may get question from here. Again, this part I have already explained. It is overall view, whole clinical picture, including antenatal, intrapartum risk factor, maternal observation, fetal observation, contraction, progress of labor, that will help in coming up in any action plan. Okay, so this part I have put it in blue color, and this is the change from the new guideline. Now, if fetal heart concern is there, then what you will do, either call someone for help, or you can change over the method. What is the changeover of method? It is CTG. After intermittent is not working, you have to do CTG. Or if the patient is in the midwifery care, then patient has to transfer to the obstetric led unit, because we already know that CTG monitoring is available only in obstetric units. But if the again, this part I have already explained, and this is there in the last guideline also. If we put the patient on CTG monitoring and we observe the CTG for 20 minutes, but if the CTG becomes normal, then for 20 minutes, then there are two possibility. Either patient can be put back on intermittent auscultation, but if the patient wish, then CTG can be continued. From this line, you will find a number of questions. These were there in previous guideline also. Okay, now after intermittent fetal monitoring, two methods. What is the second method? We already know this very well. That is a CTG machine. CTG monitoring. Already every one of us, we know we are doing CTG. So this is a CTG machine. uh, I'm not explaining about the CTG machine because there is a previous CTG class, that is a big class I have taken, that I have explained everything. But this will be attached, these are the transducers. They will be attached to the maternal abdomen, and this if they feel fetal movement, this knob they will press. Okay, and here we get heart. This is the heart trace, and these are the contractions. Okay, so this is the tocodynamometer. On the mother abdomen, this is mother has to press if fetal, if she feels movement, and here the fetal heart is recorded. This is the fetal heart, and this is the contractions. Okay, I'm not explaining because you all are using this. Okay, so what will happen with the CTG? CTG, you know that a patient has to, it will restrict the mobility, and also it will also restrict option of labor in water. Now, with this, patient cannot go in water. And if the CTG trace is normal, then we are very happy that baby is doing well, labor, coping well with the labor. But if the CTG changes or not normal, then continuous CTG has to be done, and full assessment has to be done. For intrapartum risk factor, any sepsis is there, meconium is there, slow progress is there. What is the problem? Why there had been CTG trace change? Okay, another third method of monitoring, so is the telemetry. So this is a telemetry. Now, what is the difference between CTG and telemetry? Now, you guys, you can see all these, this is like, see, When we do ECG, these kind of electrodes are there. So these kind of electrodes are there, and this is the the machine is there. So previously, these in CTG machine, this we have to uh, with a belt, we have to tie it, okay, put it over the maternal abdomen, and mother has to lie down, okay, on a bed. She can't move or something because of all these things. But this is the wireless CTG. This is the wireless transducers. So they will be kept charged, and they're put like that. And with this, patient can roam about in whole room, and here from the transducer, the CTG machine will get the signal, and fetal heart rate and contraction whatever will be recorded. Okay, so uh, like this is the telemetry or the wireless system transducers. The good point about that is that patient can roam about. But if some you think that signals are not getting, or loss of signals is there, then in that situation, either the distance can be reduced between base unit and the woman. If she moves very far from the machine, then CTG will not get, this machine will not get signal. So patient can roam about, she need not to stick to bed, but she in the vicinity of that field, the patient has to be there. These questions so many times have been asked in part 3 exam, when the role player asks that I don't want to lie down on the bed. So what are my options? So this you have to explain. On the other side, let me tell you, the telemetry, it is not available in all hospitals of UK. Okay. So if the role player asks you about telemetry, then you have to say, I need to make it, I need to arrange for it. I will see for it, because this is not that every hospital have this machine. So this is about the telemetry. This more than this information is not required. Now, what is indication for continuous fetal monitoring? So again, as per the previous guideline also, so there are certain antenatal risk factors like previous cesarean or any other uterine scar, hypertension of the hypertensive disorders of pregnancy that requires medication, prolonged PORM more than prolonged rupture of membrane, any vaginal loss that is more than sure, that means from where the bleeding is coming, infection or like sepsis or chorioamnitis, and diabetes mellitus pre-existing or GDM that requires medication. So these are the antepartum or antenatal risk factors. Now again, other antenatal risk factors, non-cephalic presentation, breech, transverse lie, oblique, IUGR. We already know the baby weight is less than third centile. Small for gestation, baby weight is less than 10th centile, or abnormal Doppler features are there. Oligohydramnios is there, or advanced gestational age, that is a post pregnancy more than 42 weeks of pregnancy, polyhydramnios or anhydramnios, or reduced fetal movement before the onset of contractions. So these are the antenatal risk factors. Okay, so we back hypertension, prom, bleeding more than show, sepsis, type 1 or 2 diabetes along with GDM, a non-cephalic presentation, FGR, SGA, advanced gestational age, reduced fetal movement before the onset of contractions, and hydramnios or polyhydramnios. So these are the intra-antenatal risk factor that we have to arrange continuous the CTG monitoring. Now, whenever the patient is coming or any risk factor is there, it is overall assessment we have to do again. Maternal risk factor, fetal risk factor, new risk factor that is developing in the intrapartum. What are the contractions? Fetal heart monitoring along with the contractions. So, in person, every hourly assessment is done, and if any flaw is there, so another person that with a fresh eye can see. So all this assessment has to be completed. or all these that need to be done before you think of when the woman on CTG. Okay, so this is just about the, what are the observations we are doing or risk assessment we are doing. Now it is the intrapartum new risk factor. This list is important: antenatal risk factors and intrapartum risk factors. Why? For part 3 exam, you have to speak in your, use this knowledge in the station. For part 2 station, direct questions come. Okay. So, what are the indication for continuous monitoring for intrapartum risk factors? So these are contractions, longer contractions more than 2 minute time, or usually contraction will should be there somewhere between 30 to 45 seconds. So now you can understand if the contraction is more than 2 minutes, so yeah, we have to see why. So CTG monitoring, and if it is more than 5 contractions in 10 minutes, normally there should be 4 to 5 contractions, but if it is 5 or more than 5, then again CTG. Meconium, we already know, we are patient to be put on CTG monitoring. Pyrexia, like either one time patient has 38, or two time 35.7 degree Celsius. So sepsis, chorioamnitis, if the pain that is different from the contraction, that we already know. If the pain is different from the contraction and the patient is labor, what it could be? It could be either abruption, and if there is a previous scar on the uterus, it could be some trouble with the scar. Okay, so pain uh, like different from the pain of contraction. Hmm? If any fresh bleeding develops in the labor, that means some problem is there. If the blood stain liquor not associated with vaginal examination is more likely to be uterine origin. Maternal tachycardia, pulse 120 or 2 times 30 minutes apart. Severe hypertension more than 160, blood pressure more than 160, 110. Hypertension, if it is 140/90 blood pressure, it is more than 2, it should be at least 2 readings 30 minutes apart. If it is severe, single reading. And if it is mild, that is 140/90. So there are 2 consecutive readings 30 minutes apart. And proteinuria, either 2 plus, or if it is 1 plus, uh, it is either 2 plus on urine analysis, the 2 plus protein, or single reading of high blood pressure, uh, or raised diastolic blood pressure. So 2 plus your protein, and plus the reading of high systolic or diastolic blood pressure. Confirmed delay, first and second stage of labor, oxytocic use, and regional analgesia. So these are the risk. Therefore, it is an ongoing assessment started from the intrapartum, and it continues with the it started with antenatal or intrapartum, continues with the intrapartum also. So this is the intrapartum risk factor, or intrapartum conditions where continuous CTG monitoring to be done. Now meconium, if the meconium is there, we know it is a fetal, there could be complication. We are worried about the aspiration. Okay, so we want to monitor baby, and it should be the option of continuous CTG monitoring to be given. Meconium is more common in postpartum babies. Okay, it is more common in postpartum babies. Like in the previous guideline, we they specify as thick meconium, thin meconium, FBS, whatever. But in this good new guideline, they have removed all these things. Now they just want the patient to be on the fetal monitoring, and it is more common on the postpartum. Full assessment has to be done. Now this is a very common issue, that like uh, if the fetal heart is hurt rather than the maternal heart is hurt rather than the fetal heart. So what to be done? So auscultation can be done with a PNAR. Bedside scan can be done, or maternal heart monitoring can be done with a pulse ox. or like fetal heart detection can be done with a scalp electrode. Okay, because these are the few things differently that can be used. Or palpation of this we do routinely when we are listening to fetal heart. We palpate the patient pulse and we listen to the fetal heart. We'll able to find differentiate in between them. Okay, fetal heart maternal pulse rate usually it will be near in 80-90, and the fetal heart we already know it will be for 140 plus. If it is like in the normal range, it will be any in the range only. So we'll be able to detect it. But yes, if there is a issue that the fetal heart is listening, maternal heart is listening rather than fetal heart, then you have to change the mode of fetal monitoring. Consideration for scan, consideration for fetal scalp electrode, and palpation of maternal pulse can be done. Okay, so this is for the first stage of labor. If you are listening that fetal heart, maternal heart rather than fetal, but this assessment is more common and create mistakes during the second stage of labor. So, if differentiation between maternal and fetal heart cannot be done in second stage, then urgent review by the obstetrician or senior midwife is necessary. And if CTG test should be of high quality, if the CTG trace is not coming good quality, then all readjustment or changing of the machines or consideration for fetal scalp electrode has to be done. That means we have to, if we are unable to differentiate, we will call for help, or we will change the CTG position. We'll do the scalp electrode. Now you guys can understand that in second stage of labor, doing scan will not be a feasible option when the patient is, you just pushing. That time doing scan is difficult. So this way you will sort out the issue in the second stage of labor if you are listening to the maternal heart rather than fetal heart. Okay, this was the just basic thing. Now what are the updates in the guideline? Now, when the CTG is reviewed, these things we are looking, this thing in the, this from the ages. We look at the contraction, fetal heart rate, baseline, acceleration, and deceleration. Okay. Now, I'll be explaining each part of it, then categorization of stage. Categorization of CTG, the way it has changed when the new guideline has come. Now, contractions. So, contractions, how the categorization of contraction is this new guideline is doing. So, if it is less than 5 contraction, then they will put white color. Okay, white. Now, it is a color coding. Previously, they used to give us features such as reassuring and non-reassuring, but this had been changed in new guideline. Now they give colors. So they put these things, CTG components in color. So it will be white, amber, and red. So white, so for contraction, white will be less than 5 contraction per minute, then you will contraction will be white code. Code amber if the more than 5 contraction per 10 minute, or there is hypertonus. Now what will do if the contractions are excessive? So you will do, we already know, will reduce or stop the oxytocin, consider tocolytics, that is a terbutaline 0.25 milligram subcut, or pain relief. So this will be the treatment. This we know from our previous knowledge and the previous guideline also. So for contractions, guys, there is no red, the mark they have given. So for contraction, there are two categorization: white and amber. Now fetal heart rate. Next component of CTG is a fetal heart rate. Fetal heart rate, we know fetal heart rate. So what fetal heart rate can be calculated by looking mean heart rate excluding acceleration and deceleration over a period of 10-minute time. What does it mean? Like in the CTG trace, you will look a segment for 10 minutes. So this is 10 minutes segment, and you will make it sure that in this 10-minute segment, fetal heart rate has to be stable. Acceleration, deceleration should not be there. Then you'll be able to able to find out baseline heart rate. And please follow this definition, because I have seen people making mistake in calculation of this basic parameter in CTG, that is the fetal heart rate. I'm repeating it again. When you have to calculate fetal heart rate, take 10 centimeter segment of your CTG trace, make it sure that the acceleration and decelerations are excluded, then you will find a baseline rate. So this is the fetal heart rate. Okay. So this is the picture that I have put it here. Now, how the RCOG, what the new guideline has done. What is the so white color code when it is between 110 to 160. Now 110 to 160. So now this is the previous CTG classification. For the comparison, I have put it here. So this is same. Okay, so this is same. Now come to amber. Amber code will be when fetal heart rate increase by 20 beats or more than 20 beats. Okay, then it will be amber. If it is 100 to 100, then it is amber. If we are unable to find out baseline rate, that is amber. So this blue thing what I have put, this is new in this guideline. Previously this is the non reassuring. Previously this was a non reassuring. So there is a change. Can you guys appreciate this change? Is it clear, people? These blue thing are changes in the new guideline. So this is the amber code. I hope I'm making sense. And this is the red. It is fetal heart, uh, less than 100, more than 160. Now here this is the change. Previously it was 180 above. This guideline, red becomes 160 above. Okay, so this is the fetal heart rate color coding, and these blues are the change from the previous guideline. This is change in the fetal heart rate categorization. Any one of you have got any questions that can ask me, or I should move ahead? Any question with this, or is it clear? Any question?
Ma'am, ma'am, why is this cutoff of 160 being taken and not that 180?
They have changed it in the new guideline. This why answer I can't give, because you why usually why we have to like why the fetal heart should go 180, then we put at abnormal. In my opinion, more than 160, now they have done right. Previously, like if I see my if you see clinical practice, you would never allow any patient heart to go above 180, then you will think of putting that in abnormal, isn't it? Usually we take 160 only. And again, this is the update from the guideline.
Because there's a little confusion in the amber. Suppose we are taking normal as 110 to 160, and amber we are saying that it is 20 beats above the start. And if the baseline at the start of labor was 160, then will it, like, when it goes to 180, will it be amber or will it be red?
No, no, it will be red only. More than 160 will be red. It will be red
Okay, ma'am.
only. More than
Okay.
the moment uh, I find this new classification is better than previous one. Previous one is confusing. This is good classification. Like to me, it appears like that. So this is 110 to 160. We already know this is normal. Now in amber, uh, if like see, if the patient you started the CTG and the patient was in white zone, and from the white zone, if there is more than 180 120 more than 20, then it will become amber. And if you think at the start that it is 160 or maybe more, then you will put red. And at the start, if you think the fetal heart rate is less than 100, you will put that already amber.
Understood, ma'am. So the more than 160 is at the start of the labor.
Yeah, what you're saying?
That
What
more
you're
than
saying?
160 is More than 160
Already
beats per
read.
minute. It's already read at the start of labor.
Yes, yes, yes. It is already. If you started the CTG tracing and you see that it is 162 or whatever, more than 160, you will directly label this as red. We have got red code, and according to red, you will do the classification of CTG. That will be
Yes,
coming in
ma'am.
upcoming slide, but that will be pathological already.
Now it's clear. Thank you so much, ma'am.
Yeah, yeah. So, what they write about the fetal heart rate, that normal, we already know it should be 110, 160. You may find lower fetal heart rate in postterm pregnancy. You may find higher baseline rate in preterm pregnancies. Okay. And if the heart rate is increasing, you can think of sepsis or you can think of hypoxia. And if it is like baseline is this for then, like if it is less than 110, because 110 is a normal, less than 110 will be the amber feature. uh, so in the amber feature, usually usual care will continue, and then they will keep on doing reassessment for CTG. Now coming to the variability. So what is this variability? These oscillation in the fetal heart rate is called as variability. Usually they occur 3 to 5 in 1 minute. If it is 1 minute trace, usually 3 to 5 oscillation will be there. Now, how to calculate it? People make so much mistake here. What you have to say, you have to take 1 minute trace. Like this is a 1 minute trace, so I will take this 1 minute trace. Okay, so this is the 1 minute trace, and I will calculate the lower part of it, upper part of it. So this is the variability, and this one box is 5 beat per minute. Okay, and it is moving ahead. So I can see the variability here in this trace will be nearing 7 beats per minute. So more than 5 is normal. So we have got normal variability here. CTG is important, people. For part 2 people, you get labor ward questions. They give trace also. So every small part is important to understand. In part 3, it is given in labor questions. Also CTG, you have a teaching station. And I find people make lot of mistake here, because when I take mock, so these are the basic things. Okay, so you should know, if your basic parameters identification is right, the CTG becomes very easy then. Okay, this way calculation, 1 minute race excluding acceleration and deceleration, you will use to calculate your variability. Is it clear? Variability calculation, I think it is clear. No one is asking question. Now this is the color code for variability. 5 to 25, we are very happy, white. Less than 5 for 30 to 50. More than 25 for 10 minutes. Okay, so this has been again changed. In previous guideline, more than 25, they have put the category 15 to 25. Now they have reduced it to 10 minutes. So part 2 people, you will get question from this line. Okay, wherever there is a change in the guideline, just make it sure you are getting questions from there. Okay, red red will be less than 5 for more than 30 minute, less than 5 more than 30 minute, and more than 25 more than 10 minute. Again here it was 25 and they have made it 10. So these are the changes in the two columns of the variability. So I have put them in a blue color for your better understanding, or sinusoidal, that will also come in the red zone. So this is the color coding for variability. Any question in the variability part? No question. Very good. Now, if the variability 5 to 25, we are very happy. But intermittent reduced variability can be there, because that will include that will denote the period of fetal sleep. Certain medication such as opioids, we know that it suppresses, so there would be reduction in variability. And uh, like increased variability, uh, more than 25 minutes, then that represents a worsening fetal heart condition. Okay, so how a CTG more than 25 beats will look, actually this much part of the CTG I have never seen. I don't know how it will look more than 25 beats per minute. But yes, you have to like knowing it. If you think that variability is going more than 5 boxes, that means it is more than 25. That means something is wrong. Okay, so to this is the your variability. And this blues, now previously 15 to 25 minute has been reduced to 10 minute. So this is the new change in the guideline. You should know that. For part 2 people, you will get question from this part only. Okay, now after variability we move to okay, so if there is a variability, isolated reduction in variability more than 5 beats for more than 30 minutes. If it is more than 30 minutes, then where we are moving? If it is more than 30 minutes reduced, like a number we are moving. Then like antenatal intrapartum fetal risk assessment to be done, and there's increased possibility of adverse fetal outcome. Okay, if there is a radiation reduction in variability and any other CTG features are there, then it is a strong indicator of fetal compromise. Okay, because fetal variability is a marker of adequately working fetal autonomic nervous system. Now decelerations. What is a deceleration? We know that deceleration is the um, episode when fetal heart rate dips down by 15 beats per minute, 15 beats in a minute, and that will stay at least for 15 seconds or more. Okay, so exception to this trace will be with a reduced variability when the deceleration may be shallow. Okay, now like uh, we have to check the duration of deceleration, and we have to see the fetal when the fetal heart rate is coming back to normal, how long the deceleration is there, whether it is present more than 50% of traces or not. Previously like they used to write present more than 15 half of the contraction or not. But now if the fetal heart, if the contractions are present more than 50%, this is a new change in the guideline. Now it is defined as repetitive deceleration. Repetitive decelerations, you have to also see absence of presence of shouldering is there or not, and variability inside the deceleration. So when we see deceleration, these things we are doing, we already know that there are three types of deceleration: early, late, and variable. Early is head compression, late is cord compression, variable is something wrong. Okay, early we know head compression, late compression is also placental, uteroplacental insufficiency, and variable. We already know that variable because of the cord compression. Now, early deceleration. So, early deceleration, they are uniform in shape and size. They are mirror image of contraction. So, see, they will start with the contraction, their nadir will coincide with the peak of contraction, and they will return to baseline when the contraction goes off. So exact mirror image, this is the exact mirror image. So and yeah, these are the early decelerations. Early decelerations, these are considered as physiological. This is the picture of early deceleration. Now you can see deceleration, you can see deceleration, and this is the mirror image. This is the mirror image. Now variable deceleration, that means we see deceleration in relation to contraction. So in early deceleration, it is mirror image of contraction, starts with it and ends with it. But in variable deceleration, there would be no correlation with contraction. They will not they will not be correlated with the contraction. So they are you will find variable shapes, size and frequency is there. These are commonest ones, and they are not uniform. So apart from this, variable deceleration do have shoulders on each side of deceleration. So these are the shoulders. Okay, these are the shoulders, and if the shoulders are there, then it is normal physiologic response to cord compression, and it is a reassuring feature. Okay, so this is variable deceleration. uh Sometime you find a problem in calculation of variable deceleration and late deceleration. So here the start of contraction and nadir, if you see peak of contraction, this time duration would be less than 30 second. This would be less than 30 second. Okay, in late, contraction and nadir will be more than 30 second. Early deceleration recognition creates no problem. These are mirror image. Late deceleration, no relation with fetal with contraction. They are inconsistent in shape, frequency, and their relationship to uterine contraction. And you will find that apex, they are starting, and nadir, the time will be less than 30 second. Okay, you will find shoulders also. So these are the shoulders. If the shoulders are there, it is normal reassuring feature. These are variable deceleration. Now these are the contractions, and there is no relation. They're coming at their own, coming and going at their own. So these are the variable deceleration. Apart from this, I would like to show you few things. If you see this deceleration, you will find this. You can see the loss of variability is there. Loss of variability is there. You see it here. Loss of variability is there inside the deceleration. So inside the deceleration, loss of variability, that means it is a concerning feature. You can see W shape. This this is W shape. This is also a concerning feature. Okay, so these are variable decelerations. Now these are the few features of the concerning feature of variable deceleration. If the return to baseline more than 60 seconds, return to baseline more than 60 seconds, less variability inside the deceleration, or if it is a W shaped pattern and no shouldering. Can you see there is no shouldering? We just saw the normal, so there was a shouldering. Okay, now you see it here. There is no shouldering, no shouldering. This is concern, no shouldering, concerning feature. So these are the concerning features of variable deceleration. Now late deceleration, they will be uniform in shape, size, and they will occur after every contraction. They will start usually at the peak of contraction, and they will come back to normal after the contraction has gone. So contraction has gone here, and they will come back to normal here. Okay, and if you will see the onset of contraction and nadir, the time will this difference, it will be more than 30 second, equal or more than 30 second. Okay, so these are late contractions, late decelerations. And late decelerations, we already know it from our previous knowledge. These represent placental insufficiency, fetal acidosis, or fetal hypoxia. So now these are the contractions you can see. And this is here is the peak, and it is starting after the peak. Okay, and you can see uniform in shape and size, same, three contraction, three this, and all starting after it. So these are late decelerations. Now, this was a very difficult in previous guideline, but I find this new guideline is better. Again, color coding will be white, amber, and red. White, no deceleration, early deceleration, or variable deceleration with no feature. Variable deceleration with no feature. So these are the white zone. We are not worried about it. Coming to amber, repetitive deceleration. Repetitive, that means more than 50% are present. And concerning features are also there. Then it is less than 30 minutes. And variable deceleration with concerning feature more than 30 minutes. Here it is repetitive and here it is non-repetitive. That means these are not present in the 50% of the contractions. Okay, so repetitive late decelerations less than 30 minutes. So these are amber sign. Okay, so I'm repeating it again. For deceleration, repetitive variable and concerning features are there. Then it is less than 30 minutes, because every 50 half of the contractions we are getting variable decelerations. But if it is only variable deceleration and concerning feature, then as the number of decelerations are less here, they are not repetitive, so time will be more than 30 minutes. And if it is late and repetitive less than 30 is upward. Okay, now coming to red. Red, repetitive deceleration with concerning feature more than 30-minute time. Repetitive late deceleration more than 30-minute time. So this is much more easy to remember. Repetitive variable and concerning feature more than 30 minutes, or repetitive late for more than 30 minutes. And single prolonged acute bradycardia or single prolonged deceleration more than 3-minute time. So these are red. Okay, so this way, it is a little better, I think, from the previous classification to remember. But yes, you have to remember it, then only you'll be able to solve questions. This is the previous classification that I have put, but I'm not reading it. This is just for your, you know uh, just for your like comparison. Now acceleration, we already know it is more rise in a fetal heart more than 15 beats per minute for 15 seconds. So if the accelerations are there, we are happy that the baby is doing well. Now this is the categorization. This categorization is same. So we categorization is done on basis of contractions, baseline, variability, and decelerations. So if all are white, then it is normal. If one is amber, that is suspicious. If two amber and one red, that is pathological. So this is categorization of CTG trace. That is normal, suspicious, and pathological. So this is the color coding that they are putting. So this is same as the previous guideline only. Okay. The changes I have already updated. That what are the changes they have made, and what they want. So what they want, like in onset of hypoxia is more rapid in second stage of labor. So increase in fetal heart rate more than 20 minutes is a red feature in second stage of labor. Okay, if CTG now they are speaking about the second stage of labor. Fetal heart rate, if it is rises by more than 20, though we read in the fetal heart rate also, so that will be a red feature here. This is different, like what we read uh, in the fetal baseline heart rate. If any concern in CTG is there and the patient in the second stage of labor, urgent obstetric review, discourage pushing, stop oxytocin unless the birth is imminent, and collect documentation and a care plan of labor to be there. Labor plan is there. So this is in the second stage of labor. Now, if the CTG trace is normal, why categorization is three. We already know if all features are white, so it will be normal. If it is normal, then monitoring of labor will continue. Full risk assessment every 1 hour patient will be seen and documented the finding. What if the patient has got suspicious CTG? If the suspicious CTG is there and no concerning feature, then there should be, what we'll do, CTG test is suspicious, full assessment, and conservative measurement to be started. And if we see acceleration, then we are happy. This is the only on the basis of fetal heart race when other concerning features are not there. But second part, if it is suspicious trace and intrapartum risk factor is also there, like sepsis, tachycardia, meconium, slow progress, then full assessment to be done and underlying causes to be reviewed and the conservative measurement to be taken. And or what can be done, fetal scalp stimulation or expedition of birth can be done. So this is the when the you get suspicious. So if you get suspicious trace and no risk factor, you have to start conservative measures. If you get suspicious trace and additional risk factors are also there, sepsis, slow labor and meconium, then conservative measurement, review by obstetrician, or consideration for fetal scalp electrode or expedition of birth. Okay, so this was not there in previous guideline. Okay, so this you have to remember. Fetal scalp stimulation expedition of birth in if the suspicious trace and intrapartum risk factor is there. So this is a change in the guideline. Now, what if the trace is pathological? If the trace is pathological, urgently to be reviewed by obstetrician, acute events to be like uh, excluded, such as cord prolapse, rupture, abruption, and conservative measures to be started. But you have started conservative measures, but CTG trace is still pathological. What you will do in that particular situation, like urgent review and evaluation of whole clinical picture and consideration for expedition of birth. Consideration for expedition of birth. But if the new features are coming and the trace is pathological, then also threshold to be low to expedition of birth. So that means expedition has to be done. Previous guideline, when the trace we used to get pathological, first they used to exclude acute event, then they used to do fetal scalp stimulation, then they used to do FBS, then they used to do then they used to do this thing, expedition of birth. But now everything has been changed. Now fetal health scalp stimulation have moved towards the pathological towards the suspicious CTG with risk factor management, and from pathological CTG FBS have been removed and as fetal scalp electrode has been removed. Now it is conservative reassessment of the patient for like acute event, review by the obstetrician or senior midwife, and consideration for conservative measurement or expedition of birth. So this is the change in the pathological management management for pathological CTG. That is a different from the new previous guideline. Anyone any question till now? Any question till now? Any question till now? No question. Okay. So
Ma'am,
single yes.
can you please repeat the one previous slide about suspicious CTG, pathway for the suspicious CTG with concerning risk factor? Can you
Okay.
please
No.
repeat it again?
Yes. I'll repeat everything again. So if the CTG is normal, please review woman every hour. If the CTG is suspicious, suspicious, you have to divide in two part. If suspicious CTG and no other risk factor, take conservative measurement. Okay. And if the suspicious CTG plus intrapartum risk factor such as slow progress sepsis and meconium, in that situation you have to do full set of maternal observations. Patient you start with a conservative measurement and review by the senior professional. If the patient is improving, then it is fine. Otherwise, you will consider doing fetal scalp stimulation or expedition of birth. Is it clear?
Yes, ma'am.
Okay.
The main difference
Previous,
is about the urgency, I think, here. Like we done conservative measures in suspicious CTG with the no risk factors. But in suspicious CTG with risk factors, we did urgent review by obstetrician and conservative measures.
management, and if that is also not responding, then proceed
Then
to
we will
fetal
go
scalp.
for,
Yes,
okay,
fetal scalp
thank you.
stimulation and expedition. So this is suspicious. Now, pathological. If the pathological CTG is there, urgent review, exclude acute events, and start conservative measurement. But you have started conservative measurement also, and the CTG is still pathological. What you will do? Get senior review, consider expediting the, then expedition of the birth is only choice. You have to do the expedition of birth, and you have to keep your thresholds low. So now they have made it much easier than previously. So it is pathological CTG, do conservative, see the response of patient. If the patient is improving, then I think it is fine, conservative will continue. If the patient is not improving, expedition of the birth. This is same as the previous one. Single prolonged deceleration for 3 minutes. Urgent review. Acute event, usually cord prolapse, rupture or abruption. Then you have to do the expedition of birth. Conservative measurement to be started, and review the patient. If the acute bradycardia, even after 9 minutes, it is there only, then we have to deliver the baby. But if the fetal heart rate recovers by 9 minutes, then reassessment to be done, whether we can still go ahead with the labor monitoring or whether the expedition is required. So this is same, this was there previously, same in the previous guideline. Now few things about the conservative measurement, what they are saying, that change the maternal position, encouraged to adopt any position, but supine should not be there. Okay. If the patient has hypotension, so if the fetal heart abnormalities is there, so IV fluid only to be given if patient is hypotensive or the patient has got sign of sepsis. For if the fetal heart abnormality will not be the sole indication for giving IV fluids. But if the patient is hypotensive because of the epidural top up, or in that situation, because sudden hypotension will also occur when the epidural is sited, that also loading, we already know that if IV fluid to be given. Excessive so this is for the hypotension they put in the guideline. If the excessive contraction frequency is there, what you will do, we know everything. Stop oxytocin, give tocolytic, but oxygen should not be offered. Okay. In the previous guideline also, for any of the trouble in the intrapartum period, they were not offering any oxygen. The fetal scalp stimulation, if the CTG is suspicious and some risk factors are there, digital fetal scalp stimulation. After that you see CTG, if there is an acceleration, then it is fine, continue monitoring. But if you do fetal scalp stimulation and there is no acceleration, then in that situation there is a compromise. Please do expedition of birth. Okay. So this is all about the fetal scalp stimulation. We were doing according to this guideline fetal scalp stimulation in suspicious CTG with risk factor. So do this stimulation, look for acceleration. If acceleration is there, be happy, monitor the labor. If it is not there, baby is not doing well, compromise is there, please do expedition of birth. Now, what about the record keeping? So, now few things you should know that, like will not come as a question, but you should know that time and date should be set. Paper speed is 1 centimeter per minute. You might have seen I showed you the CTG and the paper speed was 1 centimeter per minute. Now, in CTG traces, labeling of the patient name, date of birth, NHS number to be done. Okay, how much, what do you think? How many years the CTG to be kept? 25 years. Electronically it is stored. Now, this question comes in the exam. If the delivery is there and the baby has got hypoxia or come out with some trouble, how long the CTG has to be kept? Indefinitely. If any possible adverse outcome, you have to keep CTG trace whole life. Okay, indefinite period of time, CTG to be kept in your recording system. Apart from this, there should be a tracer from the if like sometime what the people will do, CTG trace will be taken for teaching purpose or whatever the purpose. So what they want, there should be a tracing system or tracer, so that they can keep eye if the CTG is getting removed or from the system, or if it has been taken away by someone. So these are the few things that also know, that is a record keeping for CTG. So main important part here is this: if there had been any adverse outcome of labor, CTG has to be kept indefinitely. That's all I had to say about CTG. Now this is the update. I have make a table. I had created a table that is a summary for NICE guideline. So contractions, again I'm just repeating it, but the same thing we have done. For contraction, there are two color codes, white and amber. Less than 5 contraction is white, more than 5 contraction is amber. There is no red here. Fetal heart rate, white is 110 to 160. Now increase in baseline rate by 20. That we already saw in few slides before. Both in first stage and second stage of labor. In second stage of labor, they are putting this feature as red. Okay, I have just showed you a slide. Increase in fetal heart rate by 20 is amber feature, but in second stage it becomes red. So increase in fetal heart rate by 20, heart rate between 100 to 109, and we are unable to determine fetal heart rate. So these are amber feature. Red above 100, below 100 and less than 60. Above, below 100 and less than 60 is the amber feature. What about variability? 5 to 25 we are happy. If less than 5, in between half an hour to 50 minutes, more than 25 minutes for 10 minutes, then it is amber. If it is less than 5 for more than 50 minutes, here it is still 50 minutes, here it is more than 50 minutes, then here it is up to 10 minutes, here it is more than 10 minutes. So it is easy to remember. Or sinusoidal, so these are the red features. Decelerations, no deceleration, early deceleration, variable without feature, so these are the white. Amber, repetitive deceleration with concerning feature less than 30, here they become more than 30. Variable deceleration with concerning feature more than 30, okay, here it is more than 30. And repetitive deceleration less than 30, repetitive deceleration more than 30. Acute bradycardia for more than 3 minute time. So this is the summary of color coding according to new guideline. This is a summary of the CTG categorization for CTG traces. This is same. All white, we are happy, it is normal. 1 amber, we are suspicious. 2 amber, 1 red, it is pathological. So that's all I had to. That is all about the update in this new guideline? Any one of you have got any question can ask me. Otherwise, no, we can do some question answer exercise. Any question, anyone? No, okay, no question. Then you have
Ma'am,
to answer. Yes.
one question regarding
Hmm.
the fetal blood sampling is what is the role as per the new update?
Okay, new guideline, they say we have got very less evidences that fetal blood sampling to be used as a part of fetal monitoring. So they have removed it from the new guideline. Now there is no fetal blood sampling. Okay.
Okay. Even fetal
Hmm.
lactate, we are not going to measure that also.
If it, lactate or pH can be measured from fetal blood only.
Yes,
If
ma'am.
the fetal blood is not there, so nothing can be done.
Yes.
Okay.
Right, ma'am.
So therefore now the guideline has become easy, but this will create problem. You have to delete your data from the previous guideline in your head, and you have to remember all updates from the new guideline, because your question answer will change from the as the changes are there in the new guideline. Okay. And is it clear? Any question?
Yes, it's clear, ma'am.
Okay, now you just strain your head, answer me the question. Any trial?
Ma'am, normal, ma'am.
Very good. So the like contraction 4, baseline 150, no acceleration, variability 7, deceleration early, it is normal. So this question answer has not changed from new and old, from the previous guideline and new guideline, answer is same. Do that. So there is one feature you can find out here.
And pathological,
Give me reason.
because the variable decelerations are repetitive and they're lasting for more than 30 minutes here.
Okay, so now see, from the previous guideline, if it is more than 30 minutes, it was abnormal. But in the new guideline, variable deceleration with feature more than 30 minutes is amber. No, no.
Ma'am, but it is with each contraction, ma'am. So it is repetitive, ma'am.
With each contraction, yes, these are repetitive, and
So
these
it is
are
This should be
red
red,
only,
ma'am.
ma'am.
red only. Yeah, it is. It should be red only. So the classification is so answer is same, no change. So repetitive deceleration with feature more than 30 minutes. Yes, it is red only. I thought of red, and I I thought of red, but I put amber.
One
Okay.
question regarding the the frame of the STEM, when we used to earlier solve questions, there were two nomenclatures. One was a description and one is the overall categorization. So here now
Hmm.
there will not be any description.
No, they may they can put red code or amber code.
Okay.
They will ask you to tell me what is the red feature, outline the red feature here, outline the amber feature here. So this way it can come.
But there is no terminology now as normal, non-reassuring, reassuring.
No. That is gone.
Yes.
So one feature is there.
Amber, ma'am.
Yes. Late deceleration for 25 minutes. Late deceleration less than 30 minutes is amber, more than 30 minutes is red. So there is no previous CTG and this CTG answer is same.
Normal,
This
ma'am.
will be normal, ma'am, because it's early decelerations.
Normal. So again, it has got
Red, ma'am. Red, ma'am.
red is
So this is
there. Red is there.
pathological.
Yeah, red is there, so it is pathological. So previous CTG also it was pathological, so no change in answer. Okay, so this just to revise it.
Ma'am, this is amber. Suspicious, ma'am.
Yes, very good. Lead deceleration for 25 minutes is amber. Okay, if it becomes more, it becomes red. So it is suspicious. Previous answer or new answer is same.
Duration, ma'am.
What? Huh?
Duration of decelerations, ma'am. I mean,
What
for a period of that has not been given, ma'am. But even then, it is pathological, ma'am,
Yeah.
Yeah, and
as
then we should
reduced
do like
variability as well as late deceleration.
So
cat
variability less and
carrying.
late deceleration I have put at amber. I just want to tell you that it becomes pathological. So from previous if we follow the previous CTG, so pathological answer should be FBS. But now FBS has been removed, so answer will be expedition. So this is the change from if we see new guideline, this is the answer. If we see old guideline, this is the answer. Okay, so just this message I wanted to give.
Fetal scalp electrode, ma'am.
Yes. This is like just a revision. If the CTG is not working, you have to do alternative method. You can consider doing fetal scalp electrode. You like alternative method of monitoring has to be used. Okay, fetal scalp electrode could be there, and if the facility is there, even real like bedside scan can also be done. Oh God, what I have done. Okay, so I have putting options here in this questions. Options are not there. So I'll just discuss it. So if you do the question here, so you can see that here the CTG has normal baseline rate, variability more than 5, so it is fine only. Deceleration over variable deceleration where the baseline drops by 60 minutes. So variable deceleration is there, and so it is an amber color. It is suspicious stage. So conservative measurement and stop oxytocin. But I have missed putting options here. Okay, see this. So this is the last question. So what is the category? How many features are? What features are there? You just tell me that.
The baseline is more than
Baseline
160.
amber, ma'am.
No, no.
Baseline is red. Red.
Red, yes, ma'am. More than 160 red, ma'am. Oh,
More than
sorry.
160 red,
Very
and
nice, ma'am.
variability
More than
Yes,
less
50
yes.
than
minutes.
5 or more
That's
than 50
also,
minutes. Again, red.
that's also red.
Yeah.
Two
So
red
there are
Yes,
two.
feathers.
ma'am.
Yeah.
Pathological.
Two red feature
Yes.
is pathological CTG. So
Mm.
from previous guideline, answer should be FBS. Okay,
Mm.
but as the hepatitis B is there, FBS will not be done according to the previous guideline. So what you have to do? You have to do expedition.
Expedition of delivery. Okay. Thank you,
Yes,
ma'am.
answer is expedition of delivery. So like I just put the comparison between new guideline, old guideline, what are the updates, and also how your answer is going to change. So I try to make it as easy as possible. Hope that helps you. If any one of you have got any question, can ask me.
Ma'am,
Any
if
question?
expedition means a category 1 cesarean section or category 2, it would be if in options they have given not the expedition but the category 1 or the category 2, then what we will
Oh,
choose?
okay. So I have told this in the very beginning that we cannot take any decision just on the basis of CTG. So we have to take into the account the maternal findings, fetal findings is already there with you, maternal findings and progress of labor. So these two things along with CTG. So three things you will put together, then you will decide the category of cesarean section.
Okay,
Is it
thank you,
clear?
ma'am. Yes, ma'am,
Yes.
clear.
So please, it is overall picture, not CTG cannot be used as only tool for the decision. It has to be overall picture. This is the first line of guideline. Okay, first part there. Okay. Any other question, people?
So, ma'am, if there's a baseline fetal heart rate of 164, 166, and the lady is coming labor for the first time, so then,
It is directly read.
so directly we expedite her, take her up to cesarean then, or we
No, no.
wait and we can monitor.
See, in the red category, you will put that red. But in red also, first you will do conservative measurement. You will see overall picture. If maybe there could be possibility on continuing assessment, the fetal heart will come down. Then you will recategorize it and the laboring monitor laboring to be done. But if you have done conservative measurement also and you see all other feature also and it is permanently red, there is no change, then you have to do expedition.
Understood. Okay,
On
ma'am.
I'm just saying these people again and again. only on the basis of one feature, that the tachycardia is there. You can't do every cesarean section for every patient. For if the one feature is red, put that in a red category. See overall picture, do your conservative review, continuously monitor the patient, reassess the patient again. Then on the basis of reassessment and how the patient is improving on your conservative, you will again do the recategorization of CTG. Then you will decide accordingly. Does that make
Oh,
sense?
yes, ma'am.
Okay. Any other question? Okay, so if there is no question, then bye and thank you for joining.